Hi, I'm Joelle Puccio, and this is a presentation that I recently gave at the Office of National Drug Control Policy and Centers for Disease Control and Prevention Joint Conference in Atlanta, Georgia. It was for the High Intensity Drug Trafficking Area Heroin Response Strategy Symposium. So, one thing that I like to always begin my presentations with is that the land that we were standing on there, in that case, which was Atlanta, belongs to the Chickasaw and Creek people. And that's particularly important to mention at a conference like this because Indigenous people, people of color, and particularly Indigenous women and women of color have endured generations of abuse and oppression at the hands of law enforcement and healthcare providers. So it's really important to keep that context in mind and when we're thinking about the health problems experienced by these populations, because we did that. That is our fault. Another thing I like to mention is that my pronouns are she, her, and they, them. Also, a little bit about me personally. I no longer use illegal drugs because as a travel nurse, I get drug tested like every 5 seconds. But in the past, when I did have more freedom to choose what I put into my body, I was a lot happier, I was a lot healthier, I was a better nurse, and I was really just frankly better to be around. So, diving right in. Harm reduction needs to be defined at every presentation that I do. Harm reduction can be applied to anything, and it should be applied to everything. Harm reduction is seatbelts, it's condoms, it's stopping at stop signs, it's traffic lights. One thing that a lot of us do that's incredibly dangerous and risky is ride in motor vehicles, and we don't think about all the different strategies that we use for harm reduction when it applies to motor vehicles. A lot of times people think harm reduction means that we just want to issue every 4th grader a bag of heroin on their first day of school, but that's not really what it's about. Harm reduction is quite simply exactly what it sounds like. It can be, as applied to drug use, it can be using less. It can be using in a safer manner, such as smoking your methamphetamine rather than injecting it, or it can mean not using drugs at all. All of those strategies are going to reduce the harms. The definition by the Harm Reduction Coalition that's up here right now is really useful, especially as it says we're looking at reducing negative consequences associated with drug use, not necessarily caused by drug use. Harm reduction begins with language. Language helps us in our own minds figure out how we think about things. Language also sends a really clear message to the people that we're interacting with in our daily lives, whether or not we have respect for them as people. So it's really important to use person-first language. The word drug addict is just, it's got really nasty connotations, and it's not clinically precise either. So what we should be saying is person with substance use disorder, which is the correct DSM5 terminology. The word addiction and addict isn't really useful anymore either. It means so many things to different people that it has become practically meaningless. We also want to make sure that our language is value neutral. So when you're describing the effects of substance use, it's better to use words effects rather than consequences. People who use drugs don't need to feel more like they're being punished than they already do. And again, we use differences instead of deficits, especially when it comes to interpreting data obtained from studies on brain imaging. Those studies don't really give us any clinical data about what the person actually looks like. They just tell us what their brain looks like. So we don't really know if those differences are deficits or not. Another thing that's really important to keep in mind is being gender inclusive. By some estimates, 40% of the young people today identify somewhere along the LGBTQIAA spectrum. And so it's really vital to get rid of our binary checkboxes on our forms and to just keep in mind that not all pregnant people identify as women. And if you're unsure of what to call somebody, just ask. This isn't something that is optional. This is what is happening, and we need to get on board or get out of the way. The DSM-5 definition of substance use disorder. I think it's really important to keep in mind that sometimes our definitions can be a little heavy-handed. For example, I drink less coffee than almost everyone I know, and I qualify for a diagnosis of substance use disorder based on these criteria. And that's something that happens a lot in healthcare and law enforcement. We tend to have this urge to pathologize all substance use, when not all substance use is problematic substance use. People use drugs because they want to make their bodies feel different. And that's not necessarily a bad thing or a good thing or a neutral thing. It can be different things at different times. So, for the most part, drugs are not the problem. So much of the data that we have has been on samples that we have caught. So that means these people have law enforcement or social service involvement already. Their drug use may be more chaotic. They may be participating in open-air drug markets, and those kinds of people generally have lived under the cycle of oppression for generations and have poor social determinants of health as a result. When we think that we are looking at the effects of drugs, oftentimes what we're actually looking at is despair, poverty, violence, and systemic oppression. It's really impossible to obtain accurate data on people who use drugs in the context of criminalization, because we're not going to catch all of the people that are using drugs, and the people that we do catch are not going to necessarily tell us the truth, because they're trying to protect themselves from further involvement in these harmful systems. The assumption that drugs cause all of the harms that we see in people who use them, or the children of people who use them, is the easy scapegoat. But it's lazy academics, and we really need to do better at controlling for these other factors in our data collection. Perinatal substance use, like all substance use, the pattern is intermittent. So that means people don't just start using and continue using and have no change. There's going to be ups and downs. There's going to be periods of abstinence. Pregnant people in particular, they don't start using substances for the most part. Nobody becomes pregnant and then decides to go out and score heroin. What usually happens is someone is already pregnant or is already using drugs, and then they discover that they're pregnant. For most people, we see a linear decrease throughout the pregnancy. So that means the highest levels are in the first trimester, often before people know that they're pregnant, and then they decrease their use so that we see the lowest levels in the third trimester. For femmes in particular, and by femmes I mean women, other people who can become pregnant, trans people, and gender nonconforming people, all of those groups have a really high prevalence of trauma. Trauma is frequently associated with substance use disorder. In fact, substance use can be a protective method used by people to deal with this trauma, at least in the beginning. In the context of pregnancy, we have to look at polysubstance use. By some estimates, about 3/4 of methadone patients use tobacco. Alcohol is by far the most harmful substance used in pregnancy, and the only substance with really good data of permanent developmental problems in the offspring. For grown-ups, we see accidents, liver disease, sleep problems, and all the usual things associated with alcohol use. And in the offspring, we see fetal alcohol spectrum disorder, or FASD. Tobacco is a close second as far as harms. For the grown-ups, we're all aware of this: hypertension, respiratory disease, multiple pregnancy complications. It would be easier to list the pregnancy complications that are not associated with tobacco than it would be to list the ones that are. For the babies, we see a higher incidence of congenital anomalies, low birth weight, respiratory disease later in life, such as asthma and respiratory allergies, as well as sudden infant death syndrome. Cannabis is the most commonly used illicit substance in pregnancy, but the least harmful. It's been used for centuries to deal with nausea of pregnancy, but it can, in some people, have a paradoxical effect of increased nausea. So we see that when someone comes in with hyperemesis gravidarum, and then they're in the hospital for a couple days on IV fluids, and all of a sudden they're better, and it's because they stopped using cannabis. That's not super common, but there have been some studies on it. There's no good evidence of any severe lasting harm to the fetus or infant with cannabis use. We have some poor quality evidence of possible associations, but no causal relationship has been established. Stimulants such as caffeine, cocaine, and methamphetamine. Now, I include caffeine because it really works fairly similarly, and at high enough doses, we see some of the same effects with caffeine as we do with cocaine or methamphetamine at high doses. And conversely, at low doses of all of these substances, we don't see these effects. So methamphetamine, as we know, is very similar to a lot of the medications that are used for attention deficit disorder and narcolepsy. In fact, methamphetamine as a Schedule II is prescribed in this country to children as young as 6 years old and adults for attention deficit disorder. So in adults, again, with the high doses, we see hypertension, poor nutrition and sleep related to being awake all the time, and decreased appetite. And for the infants, we see dose-dependent effects of low birth weight. There isn't really any good evidence for long-term effects on the offspring. As long as they have good social supports and education, they do just fine. Now, I want to make sure that we're all clear that you cannot technically overdose on caffeine, cocaine, and methamphetamine in the same way that we think of an overdose from opiates. The drug itself, in a stimulant so-called overdose, does not kill you. So what we see is increased blood pressure to dangerous levels, and that can cause things like aneurysm and stroke. So they can be related to deaths, but they do not directly cause the death. Another thing I want to make clear is I'm by no means suggesting that drugs are good for babies. They are just not as bad as we have been led to believe. Probably cannabis is better than some prescription medications that we use for pain and for nausea as far as effects on the infant. So, opiates. Maternal effects would be poor nutrition. That can be related to decreased appetite, decreased intestinal motility, and again, in the people that we catch and the people that we study, probably related to scarcity of resources. So if you get to pick two between rent and food and not getting dope sick, which two do you think you're going to pick? That's right, you're not going to get dope sick and you're going to keep a roof over your head. Constipation can be a problem in pregnancy, constipation and hemorrhoids already, and when we use opiates, that decreased intestinal motility can aggravate those problems as well. Accidental overdose. This is nearly 100% preventable with decriminalization and regulation of illicit opiates and universal distribution of naloxone. The reason people overdose is because they don't know how strong what they're taking is. They don't even know if what they're taking is heroin or if it's fentanyl or what other kinds of adulterants are in it. So if we had a climate where you could go to the corner store and buy clean heroin and you know exactly what kind of dose you're taking, we would almost eliminate our overdoses. I also think naloxone should be in every medicine cabinet, in every first aid kit. It should be like Band-Aids. We should all be carrying it right now. The other issue that we have with opiates that would also be completely prevented with decriminalization and regulation is infections if injected. So we're looking at HIV, hepatitis, staph, endocarditis, cotton fever, things like that. If we had needles and clean heroin readily available for all adults in this country, those infections would be just exponentially decreased. Medication-assisted treatment is the gold standard in pregnancy. And by medication-assisted treatment, I mean treatment with buprenorphine or methadone. A lot of times healthcare providers say, well, they're just going to be on methadone for their whole life. Isn't the point of treatment to get off opiates? No, the point of treatment is to stay alive. The point of treatment is to not die of overdose. The point of treatment is to not get HIV and hepatitis. Continued use of illicit substances while in treatment does not mean the person has failed treatment. It means treatment has failed the person. So if that happens, we need to increase the dose. Also, if that happens, it's happening at a much decreased level. So let's say somebody's injecting 4 or 5 times a day, and then they get on methadone and they're only injecting 4 or 5 times a week. That is a phenomenal success and should be celebrated as such. I like the term opioid agonist treatment, or OAT. It's a more precise term because it explicitly excludes naltrexone or Vivitrol, which is not approved or recommended for pregnancy and frankly has pretty terrible efficacy data at this point. I also like this term because it's not medication-assisted treatment. We would never call insulin or Lipitor medication-assisted treatment, even though both of those therapies should go along with some information about diet and exercise and lifestyle changes. The medication itself is what is doing the work, and the medication itself, as far as methadone or buprenorphine, is what is doing the work of preventing overdose and relapse and morbidity and mortality. Newborn abstinence syndrome, or newborn opiate withdrawal, which is a term that I like better. It's important to know that this is specific to opioid exposure, and the reason I say that is because there have been times in the past when hospital policies have not been entirely accurate that we have created opioid dependence in babies. There was one baby whose mother only tested positive for cocaine. She said she had only used cocaine. The baby only tested positive for cocaine, but we gave that baby morphine for weeks, which was very inappropriate medical treatment. Newborn opioid withdrawal is temporary. After days to weeks of treatment, it's resolved and the baby goes home just as healthy as could be. It's unpredictable, so we don't see an increased level of NAS with an increased dose, which leads me to believe that it is related to more than just the drug itself. We also don't see newborn opioid withdrawal with every infant that has exposure. So to my mind, that means that it's the drugs plus something else, probably social determinants of health. Presentation itself can be tricky because a lot of the signs that we're going to go over on the next slide can be really similar to normal newborn behavior, and particularly to premature newborn behavior. And when these families are discouraged from seeking medical care, as they are in our current climate of criminalization, we can see a lot more preterm births because of lack of access to prenatal care. Newborn opioid withdrawal is treatable. We have pharmacological and non-pharmacological interventions, so these babies can be kept relatively comfortable before they're completely resolved and go home. Like I said before, it has an excellent prognosis. Once the acute withdrawal period is over, there's no good evidence of long-term complications. One important thing to note about NAS and NOW is that symptoms are something that is reported to the healthcare provider by the patient, so babies can't have that. So these are all the signs of NAS and NOW. We get increased muscle tone, which means the babies are just kind of flexing all of their muscles all the time. We get tremors, which is one of those things that can be a very normal newborn behavior. Even in babies up to 38, 39 weeks gestation, they can still have a little bit of that neurological immaturity that leads to tremors. Skin breakdown is a complication related to tremors. So if you're wrapped up in a blanket and you're just shaking constantly, you're going to end up with some rug burns on your bony prominences, such as heels, knees, elbows, even the chin sometimes, because they just shake their little heads a whole bunch. We see irritability, which means that they take longer to fall asleep. When they get upset, they're really upset, and they take quite a while to calm back down again. We see poor feeding and weight gain. Now, feeding when you're a newborn is a set of 3 brand new skills: suck, swallow, and breathe, and you have to coordinate them all together. So it takes a tremendous amount of energy and focus. So if you're trying to do all that and you're distracted because you're in the pain of withdrawal, it can just be really difficult to eat. We also see some stomach discomfort with withdrawal, and that can add to the difficulties of feeding. We can get excess burping and even some vomiting if the feeding volumes are too large. So all of this can lead to poor weight gain. Another thing that can lead to poor weight gain is that increased muscle tone and tremors that I was talking about. All that muscle activity can cause increased use of calories. So sometimes, since we can't increase the volume of the feedings, we have to increase the calories of the milk. We see poor sleep, which is related to that irritability. A baby without newborn opioid withdrawal, if they're sleeping and they poop, they just keep sleeping until it's time to wake up and eat again. A baby with newborn opioid withdrawal, if they poop, they might be extremely uncomfortable and they're just going to scream and scream and scream until you change that diaper and rock them back to sleep for a half an hour. So it can be really tough to get these babies enough sleep. Now, I've never seen seizures, but I have read in the literature it is possible. If this is left untreated, we do see seizures. The reason we never see seizures is because these symptoms don't come on all at once. We all know how drugs work, right? You don't pull the needle out of your arm and instantly go into withdrawal. It takes a little time. So we don't see these babies getting born and cut the cord and instantly they're in the throes of pain. It comes on gradually, usually about 12 to 36 hours after birth. And it starts with just a little extra irritability. Maybe they don't eat very well. Maybe they're hard to get to sleep. And then the signs tend to just kind of ramp up a little bit, and then we can tell really easily when they require treatment, or if they're going to require treatment at all. Treatment is parents, and parents are treatment. I can't say this enough. The interests of the baby and the parents cannot be separated. The baby wants the parents want the baby, and both of their health is better if they're kept together. Parents' own breast milk and skin-to-skin is by far the best treatment, including morphine. It's better than morphine. It's the best possible treatment that we can give to these babies. Social supports for the parents are really important. So that means making sure they're able to get to the NICU. Do they need cab vouchers? Do they need food? Do they need a more welcoming environment? Basically, whatever that parent needs should be provided so that they can be in the NICU with their baby all the time. The environment of the NICU is really important. I've worked in several NICUs where it's just a big room and it's loud and there's monitors going off and there's babies crying and the lights are on 24 hours a day. And if we wanted to design a worse environment to treat a baby with opioid exposure, we couldn't do it. That is the worst environment possible. So it's really important that we move to a NICU environment with private rooms where we can have a dark, quiet environment where there's space for the parent to be at the bedside. And it's important to note, too, that a lot of these parents are recovering from either a vaginal birth or a surgery. And so we need to have a comfortable space for them where they can have food nearby, where it's close to a bathroom. Feeding for these kids sometimes needs to be more frequent and smaller volumes, like I talked about. The timing and consistency of the score and medication is really important, because if anyone has ever been around a newborn baby before, you know that if they're hungry and their diaper's wet, they're going to be screaming and shaking and acting like they're in pain. So oftentimes what we need to do is change the diaper, wrap the baby up, give them 10 or 15 mils of their feeding, and then do the score. Scores in themselves are also going out of vogue right now, because a lot of the things that we score babies for, we give them points for, are just normal newborn behavior, such as yawning and sneezing and not sleeping for a full 3 hours. It's very, very normal for a newborn to not sleep for a full 3 hours. Newborns also are born with lots of amniotic fluid in their nasal passages, so they're sneezing constantly in the first few days. So what we're moving more towards is just taking from the scoring system we currently have the most important items, which are: can the baby sleep, can the baby eat, and are they consolable? Skin protection is another thing that we can do to protect these babies. Oftentimes, if they're rubbing their elbows and heels on the blankets all the time, we can put a hydrocolloid barrier, which is just kind of like a gel tape, over those bony prominences so that we don't have that skin breakdown, which is just going to increase the pain response. And then as our last resort, we have pharmacological treatment, which is different in different parts of the country. Sometimes it's morphine, sometimes it's methadone, sometimes it's other medications. So what do we do with this information? Where do we go from here? My macro recommendations would be thoughtful data collection. Newborn abstinence syndrome is sometimes the expected outcome of appropriate maternal prescribed treatment. What I'd like to do is focus on outcomes that matter. So rather than telling me how many NAS diagnoses we have, tell me about the efficacy of that maternal treatment. How is the mom's health? What does compliance look like? Our treatment system it has really bad numbers as far as efficacy goes. We're bad at keeping people in treatment, and we're bad at keeping people alive after treatment. The fact that recent treatment discharge is one of the risk factors for overdose needs to change. Our treatment system, oftentimes, most of the people that are in there have been coerced, or as I heard earlier in this conference, leveraged into treatment. Treatment's not going to be effective if people don't want to be there. Treatment is going to be effective when people are equal partners in it. It's not coercive, and it's not about punishment. What I'd like to look at is long-term infant health rather than NAS diagnosis. NAS diagnosis is not really all that important as a clinician for what this baby is going to look like long-term. Another thing that would be really helpful for me to bring to my hospital administrators would be data about the decreased cost associated with rooming in and keeping families together. If I can go to my hospital administrators and say, we're going to save this many $1 million over the course of a year if we can build a new unit that has private rooms and that keeps families together, that's going to be more effective. Another issue is capitalism amplifies the problem. Women live in a system of oppression that we just deal with every single day, all the time. We need equal pay for equal work. We need to believe victims of sexual harassment and assault and work on real strategies for prevention. We need childcare, child rearing, and homemaking to be valued as work. If we can increase access to services for women and other people who can become pregnant, they will have other alternatives to substance use. We need free contraceptive care on demand. You want to know why people are using drugs while they're pregnant? Because they didn't have access to contraceptives. We need to expand WIC, and we need free universal early childhood education in case women want to join the official paid workforce. Another thing is that we need to decrease stigma by using accurate reporting of evidence in academia and the regular media. Oftentimes, you'll see original data that is translated into meta-analysis after meta-analysis after meta-analysis until it finally makes it to the regular media. It's like practically a game of telephone. It doesn't even make sense anymore based on what the original findings were. We also need to avoid sensational language. I know it's headlines and I know that's how we make money, but it is hurting real people. We also need to fund studies that don't find expected results. I can't tell you how many studies there have been that have lost their funding or not been able to be published because they found either no effect or a positive effect of substance use in pregnancy. Micro recommendations. We need to do thoughtful prescribing. So we've heard a lot about that, not prescribing so many opiates, but it's also important to adequately treat pain. Pregnant people experience painful conditions and require adequate pain relief. Women of childbearing age experience painful conditions, and people who use or have used illicit substances in the past also experience painful conditions and require and are entitled to adequate pain relief. I heard a story recently about someone who went in for a tubal ligation, which, as you may know, is a pretty painful abdominal surgery. She was sent home after one day with nothing but Tylenol, and she had a 2-year-old. As a single mom, it is not acceptable to take care of a 2-year-old with a whole bunch of stab wounds in your stomach and no pain relief, just because she had a history years ago of substance use. We need hospital policy that welcomes parents to the NICU and to the nursery. It's terrifying as a parent to walk into a NICU, as it is. And if you're a parent who has just a mountain of internalized stigma sitting on your back, you don't need to feel that more stigma coming from the healthcare providers. So I put in quotes here, "I'm so glad you're here," because that's what we need to say to these families, because they are our best tools to care for their babies. I'll say it again. We need private rooms with adequate space to sleep for parents. We need signage, forms, and language, and a culture in our hospitals that decreases stigma. Oftentimes, staff are not intentionally stigmatizing families, but there is nothing that a healthcare provider is more scared of than someone who uses drugs. And part of that is because we don't receive any kind of adequate training on what drugs are, how people use them, and how to talk to these patients. So that inadequacy translates to fear, which can be perceived by the patient as hostility. So the first step to getting your staff to treat these patients with respect is just a basic training on substance use. We need accessible assistance for getting services. What I mean by that is all in one place. If any of you have ever had a baby, you know that it's extremely overwhelming. Not only are you in pain and recovering from birth, you're not sleeping at all, you're up all night, every night, and you're expected to go to constant appointments. You have to see your doctor and the baby's doctor and the nurses at the hospital. And if you add 6 or 7 appointments in there to go to see your probation officer and to go to drug treatment and to go get signed up for healthcare and to go to the WIC office, that's just, it's impossible. I couldn't do it, and I don't have a substance use disorder. Another thing that is really important for our hospital cultures is to enforce HIPAA. Oftentimes the stories of people who use substances during pregnancy are really salacious and everybody wants to know about it, and there have been a lot of times that I've become kind of unpopular at work because I'll be in the lunchroom and someone will come in and say, "Oh, tell me about that family. What is that mom like?" And I have to say, you know what? If you're not involved in their care, then that is not your business. And so it's really, really important to protect the privacy of these families and to let them know that you're protecting their privacy. I have lots and lots and lots of references here. Please, at any time, feel free to email me for copies of these or any other articles that you might have in mind. As a last note, this is me giving out a meth pipe at the People's Harm Reduction Alliance in Seattle, and I just want to say pipes are harm reduction. It is much safer to smoke crack or smoke methamphetamine than it is to inject it. And if you've got $10, no drugs, and no pipes, and needles are free, what do you think you're going to spend that $10 on? That's right, it's not a safer pipe. Thank you.